Can you hear in the back all right? Barbara, raise your hand. Can you hear me okay? Yes, okay, thank you. I'm Michelle Saunders. I'm the director of the Geriatric Education Center. And on behalf of both the Health Science Center and the VA, I'd like to welcome you to our first ever Dementia Dynamics Improving Care Workshop. We have a phenomenal planning committee. Dr. Tracy Cawthorn is going to be speaking this afternoon, and she is the course director for this particular course, a former geriatric fellow in psychiatry here at the VA and at the Health Science Center, now the director of inpatient psychiatry at Northeast Baptist Hospital. So you'll see her later today, and she'll give you her own welcome before her own talk. And we have a phenomenal program. It's today and tomorrow morning, so it is a day and a half. Those of you who notice there's today's agenda, and then Mark Johnson over here, our audiovisual guru and distributed learning coordinator, does these wonderful slides, and one of them is tomorrow's agenda, which you may see, but we'll have the agendas for tomorrow. We didn't want to get them out today since not everyone will be able to be in attendance tomorrow, but if you can come back, that would be truly wonderful. And again, it is just a half day. Are there any people here who are not from the VA? Oh, there's lots of you. That means you need to know where the bathrooms are. And that those are essentially, you go out the auditorium and go behind the auditorium, and the bathrooms are back there. So that's the good news. There is in your handout a sheet called Participant Profile. In the green box it says Participant Profile. If you have never filled one of these out before, please fill it out and make sure you give it to Joe Zapata over here, hand in the air, and so you know all about that. He's going to discuss the continuing education credits with you in a moment, but I wanted to thank him. I wanted to thank Mark Johnson, Barbara Giles, Tressa Edwards, raise your hand in the back, Veronica Salazar, our staff who have worked tirelessly on making this thing happen. And I'm very grateful because you have the best group in the world to work with. You're extremely fortunate, and I am she. So Joe Zapata is going to brief you now.
Hold your applause, thank you. Okay, the all-important CEUs. Okay, so again, by show of hands, how many VA employees do we have in here? Okay, awesome. All right. So, of course, if part of the VA, and you're taking VA-issued CEUs, such as AHCC-MEs, nursing, or APA, you're going to go to TMS. Plain and simple, you know how to use it. If you want some more explanation, you can find me in that, but you shouldn't. And if you're seeking those VA credits and you're not part of the VA, well, let's just show your hands. How many are seeking medical, nursing, or psychology credits and not part of the VA? Okay, these individuals have to go to the back desk at some point today and fill out a non-VA registration form. It's a simple form, you fill it out, and then the VA will take over from the credits from here, and then they'll send you all the information to fill out the CE form. But if you're getting CEs that we are providing, such as the conference, the certificate of the attendance, if you're part of the VA or not, and even social workers. How many social workers we got here? Awesome, all right. Well, you just fill out this statement of attendance form and turn it in at the end of the day for each day. So if you're going to come in tomorrow, go ahead and just bring it. We're going to give you a new sheet tomorrow. So you're going to get a new sheet and you can fill it out. So you need one of these for each day. I couldn't tell which day you can come in. So. And on the page before that, we have the instructions. If you're employed by the VA, follow these instructions. If you're not employed by the VA, follow these instructions. If you're seeking medical, nursing, or psychology. But if you're seeking activity director, chaplaincy, dietitian, LPC, social work, physician or physical therapy, occupational therapy, you'll be filling out one of these, even if you're part of VA or not. So regardless, you'll be filling out one of these. And of course, I'll be up and around. You know, if you have any CEU questions, please find me, and I'll try my best to explain it to you. And it's a little bit complicated because we have VA employees seeking VA credits, non-VA employees seeking non-VA credits, and everything in between. So if you have any questions, come find me. I'll help you out because we know how important CEUs are. So we want everyone to walk away with something for today and tomorrow. And we are a little early, so, and that's fine, right? That's okay. Okay, our first speaker for today is Dr. Veronica Shead, and she's going to be talking about from primary care to long-term care. So please help me welcome Dr. Veronica Shead.
Hello.
All right, so make sure my clicker works. So I am Veronica Shead. I'm a psychologist here at the VA in geriatrics and palliative care. And can everybody hear me? I'm using this. Let's see.
It's on.
It's on.
Just keep
but
it
he
close.
wants it to turn up.
Closer? Okay.
Not that close.
Not that close. All right. So today I thought that I would take the opportunity, since this is a Dementia Dynamics Workshop, to talk about something that is very meaningful and important to me when we think about care across the continuum for people who are diagnosed with dementia. So what I decided to do was actually put a focus on integrated care. So here at the VA, we are priding ourselves on the models of integrated care, especially in primary care. But I wanted to talk about this specifically for those who are in geriatrics and why it is very, very, very important for our dementia care across the continuum. So today I'm going to describe the various models of integrated care. I'm going to explain the importance of integrated care in geriatrics and dementia care, and identify the unique assessment, intervention, and planning needs of this population. And I'm going to do that by actually giving an example of an integrated care model that we implemented when I was actually still a fellow in Memphis. So we're going to talk about, we had an integrated memory clinic. So I'm going to describe that for you as an example of what I mean by integrated care in a specific setting. And then we're going to provide, where are you in integrating your practice, and how can you move forward and into a more integrated practice from there. So again, from this, we should be able to describe the issues of geriatrics and dementia care provision, recommended best practices of integrated care in geriatrics, and dementia care in the VA, specifically, again, because I'm going to give an example that is related to dementia care and the regulations coming down from VA front office, and development of an integrated clinic, again, that's our example, and integration across settings, so primary care through long-term care. So the idea that this isn't only for a specialty clinic, this isn't only for primary care, we really need to think about this in every setting that we have. So what are we dealing with? So obviously, we're having an entire workshop about dementia because dementia is a very serious issue for us. And specifically when we're thinking about, well, how do we diagnose dementia? What's going on with the process for getting people into receiving care for dementia? So interestingly, dementia is often undiagnosed or really underdiagnosed in primary care settings. A lot of times people aren't getting diagnosed early enough. We know the push is for us to diagnose dementia in the very early stages. And what we're finding is that we are missing dementia in the very, very earliest of stages in primary care. Greater than 1 in 7 people with dementia with Alzheimer's type live alone, and many without a known caregiver. Why is this important? Is because many times we are relying on caregivers to be the care coordinators for our dementia patients. And so we're relying on somebody who has cognitive impairment to coordinate care over many, many, many different areas. So that's a really important concern that we have when we think about care, again, from the primary care setting through long-term care. And then dementia, the Alzheimer's type, is the 6th leading cause of death, and with rates dramatically increasing over the last decade. So this is a major problem and will continue to be a major issue because, as we all know, with the baby boomers aging, we are expected to have an influx of people with dementia. So what does that mean for healthcare in general? Well, it's very, very high cost. So in 2012, the cost of Alzheimer's and dementia care totaled around $200 billion. Again, we are looking at this and thinking, well, what does that mean for us? What does that mean across all healthcare settings? And what we now know, and what we do know, is that Alzheimer's disease, with the increasing numbers, all of these numbers are going to increase. And so that means we need to find more efficient and effective ways in order to take care of our dementia population. So again, how can we do that? That parts of that is finding if we can integrate the care, or if we can get the care to people when they need it the most, then we most likely will eliminate some of the issues that we have later on. So for healthcare, so again, GAT, and when I say dementia, the Alzheimer's type, again, that is because Alzheimer's is the primary type of dementia, or the most frequently diagnosed type of dementia, but we are also talking about a great number of dementing diagnoses. So all of these, it's very important to think of that when we're talking about dementia in general, that it's not just Alzheimer's disease, and it's not just Alzheimer's disease that is going to cost us in the healthcare system. So again, the other thing is that many of our patients with dementia also have a number of other comorbid diagnoses. So they're also going to be seen and managed for a number of other things. So they're going to be seeking health care for many different reasons as well. And long-term care utilization is the primary contributor to excess health-related costs in dementia and at the end of life. The most costly time period in people's lives can be actually the last 2 years of their life. And that is primarily because of very high utilization of not only long-term care settings, but also multiple hospitalizations. Again, we can work towards eliminating some of those costs by providing much better comprehensive care. So one of the things that we think of first of all when we're talking from the beginning of this continuum is why diagnose? And really, I think it's a when should we diagnose? That undiagnosed dementia is associated with increased risk for not only acute hospitalization, but caregiver exhaustion and increased use of acute care services by the caregiver. So we're not even just talking about the patient themselves, but we're also talking about the caregiver. We're talking about the stress that this is putting on families, that people are not knowing what's going on and they're trying to manage something that they don't understand. So we need to help people earlier in the process. Healthcare utilization for persons with dementia were greatest around the time of diagnosis, but following were in line with age-matched controls. So again, there is a push when you're diagnosing dementia. Obviously, people go and have increased visits. So meaning that maybe they're going to their primary care provider, they're then referred to a neurologist, they're then referred to a psychiatrist, they're then referred for neuropsychological testing. So you're having them go to multiple appointments. Imaging may be in there as well. So you're doing a lot of things to really get a better picture of what's going on with them. And so those initial costs increase, but then you see that it becomes consistent with others of the same age. Again, those costs, though, in the beginning may help us further down the line. So what are the factors contributing to the problems that we have with dementia care and management? Well, we have a shortage of geriatric specialists. That is in every area of care. We have a shortage of people who have been well-trained and understand the issues that are surrounding the geriatric population. The next is caregiver burden. Again, we think of caregiver burden, a lot of times we think of this in the later stages of dementia, but really the caregiver burden starts even before diagnosis does. It starts when people are having difficulties with getting patients in to see a doctor, because we have a lot of people who are stuck in that middle generation. They have their full families themselves, they're working, and they're trying to figure out and manage what's going on with their parents. In those situations, we start to see that people are just trying to get by and not necessarily focus because they don't have a diagnosis, they don't necessarily have a name to what the problem is. And so in that way, the burden of care begins again before diagnosis and continues on. And then the biggest one here is fragmented care. So I'm talking about integrated care today, but we have the issue of fragmented care, where a person goes and sees a specialist on one date, a few months later they go and see someone else. Those two providers, especially in the community, have not communicated with one another. They don't have the notes from that visit. Maybe the patient had an imaging done at one point in time, but that never got back to their primary care doctor. So we have an issue with fragmented care, and again, we are asking caregivers and or people with cognitive deficits to keep track of all of these different things. Also, inaccurate or delayed diagnoses. So we have a tendency to shortcut the diagnostic process, and that a lot of times people are being diagnosed either when they come in for acute care, so they come into the emergency room, or they have an acute hospitalization, or we're dealing with them being diagnosed maybe on a screener in a primary care office. And those can lead to inaccurate diagnoses. Again, we want to make sure we're delineating which type of dementia or what type of cognitive problem they're having, because that can be useful in their care, especially early on. But we're also delaying that until people are, again, much further along than we would like them to be. We want to do this much sooner. And the other is ageism. Ageism is a huge barrier in that in some communities, in our greater community, in some cultures, they think that some cognitive impairments are a natural part of the aging process. And that can be problematic in that it does not get people in to be screened, to be cared for in the appropriate ways much earlier on in the process. And so we want to make sure that not only the community, but also providers. We have a lot of providers who are also thinking, oh, well, as you get older, X, Y, and Z happens, and not necessarily taking seriously some of the issues that you see with our older patients. So again, early detection, which allows the patient and family to be involved with planning for the future, education of the patient and the caregiver, opportunity to use treatments that may slow the progression of dementia, and gain early access to community resources and support. And again, this is really, that last one is a major, major factor in eliminating a number of the problems that we have down the line. So not only integrated care, but getting them the best resources. It keeps people at home the longest by providing those resources, not only to their homes, but to their caregivers and support and their families. This also helps eliminate problems towards the end of the disease process when a patient is no longer able to make decisions for themselves, things like advanced care planning, which we'll talk about later. All of those things are very important and can be staved off with early detection. So one of the big things is kind of the idea of differential diagnosis of dementia, and why is that important? So we want to make sure that we get the right diagnosis so that we can intervene appropriately. So identifying and treating reversible causes, informed treatment planning and intervention. It assists the patient and family with planning once again. It informs decisions regarding capacity. It helps determine the appropriate level of assistance needed with IADLs and ADLs, so all of their activities of daily living, and safety with those. And again, how they can make their home safe or what is a safe environment. They can instruct rehabilitation therapies and assist the patient caregiver providers in developing targeted compensatory strategies. Again, with differential diagnosis, we can do this and tailor these much more efficiently and effectively for families if we know exactly what's going on and what the trajectory of their process is going to be. Also, this allows us to really look at and target not only those compensatory strategies, but the strategies for care in the future. So what are the problems in getting differential diagnosis? Well, again, diagnosis remains largely a clinical diagnosis, so based on symptomatology and not necessarily is there one specific test that's going to show us X, Y, or Z. Again, that's why there's the importance of getting a greater understanding of what's going on, so a larger battery. So again, we talk about a lot of screeners, but really a full neuropsychological battery would be very helpful because it gives you a greater picture of what's going on with the patient cognitively. Terminology and classification systems are often confusing and inaccurate. Again, you're dealing with families, and sometimes the terms that we use in medical settings are not necessarily consistent, and they're not understanding what's going on. Overlapping of symptoms among syndromes. So again, we rely a lot on symptomatology, and so when we know that somebody with a vascular dementia shows some of the similar cognitive impairments as somebody who has an Alzheimer's dementia, we, again, can sometimes confuse those things. The high base rate of some symptoms, even in healthy older adults. So again, we have some normal changes that happen with aging that we have to be cognizant of as well. Cultural and societal beliefs about aging and dementia. Again, we talked about ageism. Over-reliance on insensitive and non-specific measures. So again, we tend to rely a lot on those screening measures, which we have begun to, we have very good psychometrics on them, but they do not necessarily give us the deeper picture that we really need when we're coming up with compensatory strategies or other strategies for families and intervention. Inaccurate symptom reporting and difficult to detect in the early stages. So again, it usually requires some investigation, and when we're seeing people in primary care, those patients are usually seen for maybe a 15-minute appointment. That does not usually allow for a lot of time to maybe even notice some of those earlier signs that you would with the population. So that then would require us to dig a little deeper. But again, it makes it difficult to detect those things in our current healthcare system. So, when we talk about integrated care, what am I talking about? Well, we actually have some models of integrated care. What I wanted to first start off with is just kind of the biopsychosocial model of care. And this is the understanding that when we are treating someone, we are treating the whole person. And when we are treating someone with dementia, especially, we and their family, because I do strongly believe that we aren't just intervening with the patient, we are also intervening with their caregivers. We must understand that all of these factors are overlapping. So the biopsychosocial model really stresses the fact that you understand the underlying pathology, so the biological side, what's going on physically with someone. That's what we're used to focusing on when we give someone a diagnosis. But we're also needing to understand the psychological consequences of that. What is it like for somebody to have to deal and cope with having a diagnosis of dementia? What is it like for their family to have to deal with that? Do they have some other psychological or psychiatric diagnoses? Are we dealing with somebody who has mood disorder? Are we dealing with anxiety? Again, some of these symptoms also pop up as a result of the pathology that somebody is experiencing, as well as understanding the cognitive domains that have been affected as well. Also, we need to understand what's going on socially. Where is this person living? What are the circumstances under which their family is able to help and provide care for them? What types of resources do they have? All of those things can be very, very stressful to a family. We know that our older adults definitely have some limitation on their finances at many times and are having to make some very difficult decisions about that. And we know that a lot of those burdens then go upon their families as well, especially when we're making decisions about things such as long-term care. The costs are astronomical for those processes, and so again, those can be very difficult social pressures. We also want to think about spirituality. We want to think about where is this person, how are they doing spiritually? We want a greater understanding of that. How are they going to be able to cope with this? What is their understanding of these processes? And again, even culturally, what does that mean for them? So this is kind of the overarching model of really thinking and conceptualizing care. So when you go with that, and then you think of integrated healthcare models, then we want to think of making sure that we are providing for every single one of those areas, and that we are integrating that care because it overlaps. So I'm going to show the model, and this model was introduced through the Blueprint for Change in Achieving Integrated Healthcare for an Aging Population. So this is from APA, so the American Psychological Association. They did this Blueprint for Change, and it really addresses how we should be caring for our aging population in general, and how various models and in various settings, how integrated care can look. So this work is used to encourage this model not only in practice, but also in education, research, and in policy. That we should be trying to do this in all facets so that we can provide a greater integration overall. So this is what the model looks like, and essentially what you're looking at is individual assessments. We know that each and every provider has their own individual assessment, their own lens as to what they're seeing and how they're seeing a patient. We want to then move that into sharing information and intervention planning, so that we are now not only integrating our own individual assessment, but we're using and sharing that information with others to come up with a more comprehensive plan for intervention. And then we move and we think about the individual and the coordinated delivery of care. So we come up with this individual assessment. What does that mean? We share that information across a number of providers, come up with a treatment plan, and then make sure that that plan is individualized for that patient. As you see, these circles are continuing and feeding into one another. There is no one plan, especially when we're dealing with a demented patient and their families. We need to continuously do this. We need to continuously assess. We need to continuously share information, especially when somebody is moving across the continuum as dementia patients do. So again, the idea goes from your own, as your independent practitioner, your individual assessment, then sharing that information, and then making sure that that care is coordinated in its delivery and that it is structured for the individual. And so what does integrated care mean? So it can be a single setting or a clinic, so it can be one thing or multiple things. It's holistic. So as we all hear a number of these terms over and over again, we hear there's a huge focus on patient-centered care in every single area in facet of healthcare. But what do we mean by that? And how do we provide that with the constraints that we have as providers? There are a range of presenting problems. So most people don't come in with their hand raised and say, hello, I have XYZ problem. Usually they're presenting with congestive heart failure. They're presenting as feeling fine and that nothing is wrong with them. So there is no one presenting complaint usually that we're going to see. There's the team model of care. So again, as an individual practitioner, you are doing your assessment, but again, you're coming up with this plan as a team member. That model of care means that you are then going to integrate and collaborate on that plan of care. And that's why you then will have a cohesive single plan of care. So I'm not going to get recommendations from this provider and then go to the next provider and get a whole other set of recommendations. I'm not going to have this provider send me to neurology, and then this provider is going to then send me to psychiatry, and within one setting, and over the course of 6 months, I may see neurology, psychiatry, and someone else, but then nobody has actually talked to one another. That's what ends up happening to many of our patients. They are sent for one presenting problem, something that their family then notices, and then they are then asked to, they get a recommendation to go to a neurologist. Well, that appointment may happen, it may not happen for a couple of months, actually. And so by the time they get those recommendations, there's something completely different, or we haven't, that primary care provider doesn't get that information back to then integrate that in the plan of care that they're giving to the patient or their family. So again, we want to start to move towards cohesive management and planning of care. Ongoing close collaboration, so working with others. How do we work more succinctly and efficiently with others? How do we give an appropriate consult? And fluid communication. So I know in the VA we have an excellent electronic record system. However, that usually works with, you might get co-signed to a note. If you have as many patients that I do that you're responsible for, being co-signed on a note can go overlooked and you may not integrate that, especially in primary care where panels are hundreds up to 1,000 patients. So again, we want to make sure that we have better and more fluid communication. Mental health care is also equal to medical care, as are the social concerns and the spiritual concerns. So we want to make sure, again, that we look back to that biopsychosocial model. So what are the advantages of this? So enhanced access of care, better screening and monitoring, ability to address mind-body issues, ability to address modifiable risks, increased provider and patient satisfaction, which is a big one. A lot of times when you're able to provide more comprehensive care and eliminate the need for multiple medical appointments or make that more efficient, you actually see that not only are the patients better satisfied, but also providers are as well. Enhanced triage to specialty clinics and improved outcomes. So the general principles of enhanced collaboration. So again, how do you do this? It sounds all well and good. This is idealized. In a perfect world, we would be doing this more efficiently. But how do we start? Where do we go from here? So you start where you are. You start with what you have. You start with understanding just what do we mean by integrated care. And then you meet your team where they are. So if you have a team, and sometimes you think of your team as not only just yourself, so if you're an independent practitioner, you have your own office, those are the people, those are your referral sources. Those people can be thought of as your team members. So start to think of who's your team and where are they. Sometimes we actually have a team just that's surrounding us. And meet a need. So what are you going to do? What is your focus? What type of need are you trying to meet? Go with the zygote. What is it? Start to figure out and formulate what it actually is that you're going to do. Know the culture and language. So again, know who your audience is. Know who you're speaking to. If you're speaking to other providers, if you're speaking to your patients, how are you going to communicate with them the best way? Integration may occur along a continuum within a single clinic or setting. So again, it can happen from just one type of clinic that then combines and really works on getting very good comprehensive care. And so maybe that's what you're going to start with first. Integration is not a dichotomous entity. So again, it's not you're integrated or you're not integrated. It is that we're going to have to focus on how to start to make this process work. And be available to give timely feedback. So again, if somebody else is referring to you, how can you be timely and how can you give appropriate feedback to them? So again, we have a continuum of collaboration, and so that's what this slide really is kind of going for. It's going to show how across models of how do we work together, how do we get these things to function much better. So what you're seeing is that the first one is minimal collaboration. So it's kind of the traditional specialty model. You have separate space and a separate mission. So maybe you're a primary care provider and then you refer to a neurologist who is out in the community. And then collaboration from a distance. So again, you're primary care and then you collaborate from a distance with a specific provider. And so you have a preferred provider who you actually communicate more closely with. And so you kind of have this one-to-one referral relationship. And then collaboration with physical proximity. So you all are co-located. So maybe you're in the same clinic, maybe you're in the same facility, and so you work in great proximity, so you can then go from you are separate, so you're your own provider, but you're able to maybe walk over for a curbside consultation or something like that. And then close collaboration. So it's a partially integrated system, the same physical space with shared records and collaborative care. So you're no longer just co-located. Now you are actually collaborating on the care that you're providing. And then close collaboration in a fully integrated system. So primary care and behavioral medicine as a part of the care team, as an example. And the care is integrated. So this is where you are actually not only seeing or assessing the patient together in the same place, but you're coming up with that integrated treatment plan. You're coming up with that care plan that includes information from both sides. And so that would be integrated care. So, again, we talked about specialty care, so this is the minimum to no collaboration. Not meaning that specialty clinics cannot provide integrated care, because the example we're going to talk about is actually a specialty clinic. So, for instance, you go and see the person, I'd like you to see a psychologist. So, whichever psychologist, just go out in the community, you need to find a psychologist to see. Minimal relationships between providers, no team model of care, standalone practices, screening unlikely of opening up a can of worms, and unlikely to initiate exchange of patient information to coordinate care. And I think that that's probably the major factor here, is that there's no communication as to what's been going on with the patient. The next is was that second one where you say, I'd like you to see Dr. XYZ, she's a psychologist, neurologist, psychiatrist, whoever, and that's telling you this is a specific person that I work with in the community, a specific person who I think can address the issues that you are having. So not just a generalization, but this is somebody who I have worked with in the past and will continue to work with, and I'm looking for their input on this situation. A CNL model, so a consult liaison model, so asking for a consult from somebody that you're familiar with. And typically it's not they are not formally screened for a number of different things when this is happening either. But again, they're hopefully getting them to a person who they think may be the one who can help them. And they may or may not exchange a telephone call or written information regarding care. And in shared electronic medical records, they may or may not read the notes or again co-sign something along those lines. And then co-located care, which we have actually, this is probably close to our PACT model in a number of ways. So I'd like you to see a psychologist in our clinic, I'll send you a referral. And psychologists on site, sharing space, separate treatment plans, separate intakes, but there may or may not be some clerical or administrative support. The degree of collaboration can vary depending on the patient and the providers. Services still viewed as co-located specialty care, and the providers are more likely to screen in these situations because they have an immediate referral source, and the patients are likely to present for their first visit because it's in a familiar place, so they will likely come back. And then partially integrated care. So I want you to see the psychologist on our team as a part of your treatment for X, Y, and Z. So again, as you see these opening statements as to what one would say to their patient continues to change and continues to express the relationship that you have with another provider. And close collaboration, partial integration, these are typically co-located. So again, in the same place most of the time. And they're multi or interdisciplinary team models. So again, multiple disciplines and providers who are then going to assess and provide care and work on treatment planning. And usually it's targeted programming. So this is a clinic that is working on something specific. So they have a specific goal in mind. They have a targeted program as to what the care would be. And integrated interventions with a single treatment plan. So again, they're going to work together to come up with how the treatment the treatment plan should be implemented. And then fully integrated, we take a team approach to your care. So this may even be said in front of another provider, that you may actually be seeing this patient with another provider in the room. Fully integrated care and close collaboration. Single unified treatment plan with input from all members. So again, multiple areas of the patient's care. Team model is ideally inter or transdisciplinary, and scheduled communication of treatment planning. So they plan and they work together, and they know that whoever they're seeing, they are going to actually treatment plan together, and they have that scheduled, or that's going to be done on a daily basis. So these are some of the team models of care. So there's multidisciplinary, so it's kind of additive, it has independent and parallel processes. Sometimes it's separate in discipline-specific roles, but again, there are distinct skill sets within that, and so there can be discipline-specific treatment plans, and there may be a team hierarchy within that setting. So that's multidisciplinary, and as you see, kind of the diagrams of these start to change as the care becomes more integrated. So then you have interdisciplinary, and so that's integrated, it's collaborative, common roles, shared goals, overlapping skill sets, coordinated treatment planning, and collaborative decisions. So again, you're starting to see that these things are more and more integrated, that they're working together to try to provide care. Interdisciplinary is probably going to be the first line that ideally most clinics would be able to perform, is the interdisciplinary model. The transdisciplinary model is a much higher order framework of true overlapping integration. It's holistic, shared framework, and the role, release, and expansion. So again, depending on the patient's needs, one provider may provide more care than another, and it's going to be shaped as to what the patient's needs are. And unified goal, once again, so everybody is working towards the same thing. Shared skills and cross-training, so usually this is for a team who is well integrated and has worked with one another for a long time. This is going to take time to build, and that those teams, they understand so very well the needs of their other team members that they're able to even share an assessment, meaning gathering the information that their teammate may need in their assessment process, or making sure that things are set up for the other provider. And a single treatment plan again, and shared leadership. So again, all of the players who are coming on board with the transdisciplinary model are there to work together, and they are seen as sharing the load of care for the patient. So with this transdisciplinary care model, again, it evolved out of the idea of hospice care. And so we know that hospice is probably one of the most integrated care teams that we have in healthcare. And so this approach advocates for kind of this team-based care in which all disciplines have an equally important role in the patient's care. And again, that goes back to the biopsychosocial framework of looking at the patient, making sure that you have providers to address all of those needs and understanding that those overlapping things are very important. So again, we want to make sure that we pull it all together as to what we're going to provide. And team members have expanded knowledge of the roles that each discipline plays on the team. So again, respect for the other providers and knowing and understanding their scope of practice and how that can be best utilized for the patient. The roles overlap significantly, and the transdisciplinary care naturally produces an environment conducive to warm handoffs in which the patient can move more fluidly between providers. So again, this is kind of the higher order thought of models of care. So now we're going to really kind of switch and look at kind of the VA's evolving approach to dementia care. And so again, we know that our population in the VA is aging. So greater than 40 million Americans over 65 years of age, with 9 million, we have in America that many adults over age 65, but 9 million of those individuals are veterans. And so again, this is a very specific population. This is the population that we are seeing in our medical facility. And 52% of veterans receiving care from the VA healthcare system in 2009 were greater than 65 years of age. again, that number is actually going to increase. I know we also have the influx of our younger veterans, but we're also going to see more and more of our older veterans. And right now, what we're starting to see is an influx, or we have begun to see the influx of our Vietnam-era veterans, especially, who are now entering this age group and exceeding it, and so we're seeing them and their need for care. So, what do we do? So essentially, nationally, the VA is aware of this issue, and so we have started to address it. And so they actually established a National Dementia Steering Committee, and they had 3 work groups to address clinical care, coordination of care, and administration issues. They came up with 64 recommendations to enhance VA dementia care, and 39 of those 64 recommendations are actual clinical recommendations as to how we should care for demented patients. So on the interdisciplinary, at the VISN level and local dementia committees. So at the time when I was a fellow, we were in VISN 9, and so VISN 9 elected to establish specialty clinics in order to try to address these needs. And so my local committee was in Memphis. So that's where we were able to do the example that I'm about to show you. So again, we know that they came up with all of these recommendations, so what do we do? So it's starting again, what we're going to talk about is how can you do this in your own setting? What types of questions do you need to ask yourself? What is it that you need to do as a first step? So our first step was to conceptualize and model build. So how and where will the recommendations be implemented? Are we going to do this in primary care or a memory or a specialty clinic? Again, the VISN level chose specialty clinic in VISN 9. And then what is the goal of the clinic? So what is it going to do? What are the clinic's objectives? What is the scope of the clinic? So what is it going to cover? How many people is it going to cover? Who will provide the services? You know, a lot of times, especially in the VA, out in the community and others, we come up with these great ideas for clinics, but then we don't have new providers until we're able to prove that the clinic is working. So how do we do that when you have a full workload already, and then you're going to try to start a new clinic? So again, who's going to provide the services? And what is the model of care? So we talked about these integrated models of care. So what are we going to do? How are we going to be able to in effect, put together one of these models of care in order to provide comprehensive dementia care, or at least start with that, excuse me. So, the model for implementation, so these are actually the recommendations that were brought down by the VA. So that's what you're seeing, and that's what they're kind of outlined. You see the different numbers, and we have them delineated under education, assessment, and intervention. And so as you can see, a subspecialty clinic like a memory clinic, it goes through and it shows you kind of all of the various things that in those clinics, what you might want to address, or how you might address those things in that setting. So in the primary care setting, what are the types of things you may target? In the memory clinic setting, what may you target under assessment, intervention, that type of thing? What are we going to try to provide for families? How are we going to address those things? What are we going to educate our providers with? So again, that's what all of these are. And again, these are the dementia care recommendations that the VA has passed down. So again, we have to have a goal then. So if we're going to start this clinic, we have to have a goal. And so the goal was to provide comprehensive evaluation and treatment recommendations for older adults with suspected cognitive impairment and functional decline. Again, it took time to come up with this one specific goal, but again, the goal was to provide this comprehensive evaluation. Note that it says evaluation and treatment recommendations, and I'm going to get to why. So, memory clinic objectives. So what are we going to do? What does that mean for us? So we're going to identify reversible or contributing causes. We're going to establish a diagnosis, address modifiable risks, inform treatment in primary care, initiate treatment related to cognition, mood, and behavior, and assist the patient and family with planning, including advanced directives, and inform decisions regarding capacity. So these were the objectives of the clinic. And then the memory clinic objectives continue with determine appropriate levels of assistance needed with their activities of daily living and safety, as we talked about previously. Assist the patient, caregivers, providers in developing targeted compensatory strategies. Identify needed VA and community resources. So again, within our clinic, we're going to try to do and reach all of these things. Assist with behavior manifestations of dementia, and assess caregiver burden and provide related support. So, again, that's a lot of things that we're going to try to do in this clinic. We're trying to address a number of those clinical needs that were passed down from the VA. So how are we going to do that? So we've come up with the objectives, we've come up with what we want to actually do, so how can we do this? So the first thing is figuring out what the scope of the clinic is going to be. So it's going to be a consultation clinic. It's not going to be a management clinic. So we're not going to take on the comprehensive management of all of the patient's care. That is too large of a project to do, so we are going to do it in a consultative way. Provide a comprehensive assessment. So we are going to provide this comprehensive assessment and work to provide differential diagnosis of dementia. We're also going to help to modify risk factors. So we're going to use that knowledge and try to modify risks for repeated hospitalization, falls, so safety issues, people at risk for coming in and out of the hospital. We're going to try to modify all of those risk factors. And then ongoing caregiver support for behavioral manifestations by telephone. So we will remain available to those families who we have seen in our clinic via telephone, but again, we are going to primarily be consultative. So who's going to be involved in this? And so that was one of the decisions that we had to make. So we decided that there were going to be geriatrics and dementia care specialists, so people who have a greater understanding of what's going on. In Memphis, the program director was a GeroPsychologist. She was the one who actually was the chair of the dementia committee. We had medicine, we had a geriatrician, we had a geriatric PharmD, we had psychology, so we had a representative who was credentialed in neuropsychology, and we had a geriatric social worker. So all of those disciplines worked together to make sure that this clinic was going to work. And then we also had trainees, so whichever trainees at the time were rotating through our geriatrics clinic. So those were from psychology, pharmacy, and we also had some geri-psychiatry trainees as well who were in that clinic. So what is this going to look like? So screening in primary care, so where are the patients going to come from? So the committee reviewed the literature and created a primary care clinical reminder, and it screened those who were compromised by using the mini-cog. And so they also talked about the dementia warning signs. There was some education from primary care as well. But we also required that we not just have a screen, but that we also assess the patient's function. It's very important because that has a primary role in dementia diagnosis, is a patient's functional status. So we also wanted to make sure that we were helping primary care to also look for functional decline as well. We also made sure that this screening, so this clinical reminder, it actually only came up on those veterans who are 85 and older. The reason for that is that, again, how many patients can our clinic take? And so the extreme workload, the volume of patients in our one healthcare setting really needed us to focus on one side of the population. So who's the most at risk for developing dementia? We knew that it was our 85 plus. We also said that you could do targeted screening for those who are under 85. So we didn't eliminate the fact that if you are under the age of 85, you could not come in, but we just made sure that the clinical reminder was on the chart for those who are over 85. So that means that you would then, how would you gain access to the clinic? So again, the clinical reminder, the dementia screen, so 3 on the mini-cog plus 1 dementia warning sign and functional decline is what we were looking for. Direct consult, so again, when you saw those things were present, and an objective indication of cognitive decline would be helpful, so we were looking for that in in our consults. We didn't always get that, but we were looking for it. We would also want them to order labs and imaging if indicated, so we had a recommended reversible dementia panel that we had in the set, and an order set for primary care. We completed the formal screen and clinical reminder as optional again. And referral to geriatrics primary care for dementia evaluation or care, and the neuropsychology outpatient clinic. So again, we also were making ways to what were our referral sources going to be, or what referral sources were coming into us, but also which ones were going out. So our structure then ended up being 2 appointments, 1 week apart, and we required that. And some of this was learned. I will tell you that some of this was learned trial and error. At first, it was going to just be a 1-day clinic, but we had the problem of it was just too much for our patients to deal with. So we decided that we were going to do 2 appointments, and then that also allowed us time to actually give much more comprehensive feedback to the patient and their family. So what we were able to do, we required that a caregiver or a collateral was there. We had a number of times where people who were highly impaired came in to see us by themselves, and they weren't able to give us a lot of information that we needed, and we thought that it was actually a safety risk at times. We did a morning evaluation, so comprehensive history, neuropsychological evaluation, which was conducted by a psychologist. So it was a single intake for the clinic. And then they would come back the following week for the afternoon evaluation, and they were evaluated by a specialist in a round-robin format. So they would go and they would have a 30-minute appointment with the social worker, the geriatrician, and the PharmD, as well as a session because of the information that the psychologist then had from their neuropsychological eval. So all of that was done in the same day, and then we actually would meet with the patient and care. We would give them same-day feedback as far as what was going on, and that was again part of that neuropsychological evaluation and then integrated. We did that because not only did everybody see the patient, but we also met and discussed the patient before we would give the family the feedback. We would actually come up with a comprehensive plan for them together and then go and give them feedback about that same day. If for some reason they weren't able to do that, we would call them on the telephone. We had limited follow-up with some patients because we may recommend, our PharmD or our physician may have recommended a medication, for instance, that they needed to start more immediately than going back to primary care. But for the most part, what we would come up with in our final note would then go in our final team note. So each provider wrote their own note, but our final team note would then would co-sign, and obviously we would interact with the primary care provider. And it had very specific recommendations from our entire team for a more comprehensive treatment plan. So we then had ongoing telephone support for caregivers to make sure that they were able to follow through with the resources. Our social worker was amazing in the fact that she was able to get resources designated for their geographical area and make sure that they were able to follow up on the same day. For those of our patients who were cognitively intact, based on their testing and the questioning, we were able to then do an advanced directive with them during that appointment. So we were able to get so many things done in the span of 2 clinic appointments that many people probably wouldn't have been able to get done for months by having to see that many providers. So again, the idea was that we were able to provide this comprehensive care, integrate that care, share that information with one another, come up with a plan, and then follow up. So again, that is an idealized integration for a patient, and that was really the idealized setting for somebody who was newly diagnosed. So if we think about on the continuum and post-diagnosis integrated care, then what are we going to be able to do? And we need to think about what this would look like too for not only earlier onset people, so people who are going to go through this trajectory a little bit faster. We need to look at moderate dementia levels. So what happens in that in-between part? Are we losing touch with our patients and their families, making sure that we're still there, that we're able to provide the services that they need? Severe dementia care and services. So making sure that we are able to start figuring out how we can do more integrated practice before there is a large catastrophe in some situations. And then making sure that when we're able to do early diagnosis, we are also able to educate earlier about not only palliative care, but specifically hospice when it comes to dealing with our demented older adults. With hospice care, dementia can be one of the trickiest diagnoses for hospice because they're not really sure when somebody is or is not in that 6-month stage. But what we want to make sure we are providing is that integrated team approach to their care. And so we aren't doing that very well with our demented patients until very, very, very late in the process for them. And so we want to make sure that we're educating and doing that much earlier. So introducing them to these things, again, at this first kind of diagnosis and feedback session is very important, but we also need to think of ways to continue that. And so I really, as far as being a workshop, one of the things that I really want you to do, that I started off in the beginning talking about, is I really want you to think about what this would look like in your respective area. What would it look like in your clinic setting? What is it going, how can you integrate more efficiently and effectively starting today? What is it that you can do? Is it even just getting a provider list and starting to call people or get information about who in the community provides XYZ service? And how can I provide even just a caregiver with a list of the people who they should likely go and try to see in the community? That is one step towards integration, as opposed to leaving, again, these caregivers who are overburdened or are cognitively impaired patients without anything to reach out for. So start thinking today, who do I know, what's going on, what resources do I have, who do I know, and how can I get them to someone else effectively, and how can I follow up efficiently with that? We have the issue that many providers, especially we talk about that there are not enough providers who specialize in geriatrics, but the follow-up is so important. We often lose things to follow up, and so I think that as providers, that's an area that we need to focus on as to what we can do. And training. And I'm really passionate about training, but I really think that if we're talking about the fact that we need to integrate care across providers and across areas and across the whole continuum of care, then we're going to have to train those up-and-coming providers in the same types of areas. They're going to have to learn and know the scopes of practice of other providers. They're going to have to know how to work together. If they don't know what another provider is capable of, then they're not going to be able to use them efficiently and effectively. And so we have to work much harder to get out of the silos that we have produced in order to integrate care more effectively from the beginning. And so that also begins with training. And so I don't know if anybody else has any ideas with how to move forward, but there are a plethora of other things that we can do in other areas, in other types of clinics, also with other types of chronic illnesses. So again, this is what I think that we should be doing as far as dementia care, and thank you very much for listening to me this early.
Questions, anybody? Questions, comments?
Up front.
Ethan?
Where is nursing in this process? I saw your list of all your different providers. I did not see nursing.
Yeah, so nursing, I think that nursing is very important in this process. In our clinic, so there are a number of ways, and again, this is one example. This is an example of a specialty clinic as well. And this has to do with resources. Again, we were in the VA system where we had to start this clinic without having any FTE, without having any people designated for it. So how that worked with nursing is that we actually, our nursing staff would rotate into who actually did our screens for our appointments. So we actually had people who would come in. We had our nursing staff run like the blood pressure, everything else, and give feedback on that. We also, a number of our referrals came from nurses. So those nurse practitioners who had panels themselves, as well as nurses who had found some of the things that were going on in this memory clinic. I can definitely tell you that depending on the nature of what your specific focus area is, that will increase the need for nursing. I currently work in a long-term care setting, and I will tell you that the most important providers in that setting are the nurses. They have much more interaction with our patients than we do, and so they know them better. So when I'm trying to help with a behavior modification or something that's going on, that's who's going to implement that. So just because that example didn't necessarily highlight that, there are so many other things. There's a huge need for nutrition and understanding of nutrition, and especially dementia care. We know that early on, so many people start to change behaviorally and start to like sweets and not want to eat other things. So there is a need for so many different disciplines to play a role in this that I don't want anybody to feel left out just because they weren't specifically mentioned for that clinic. But again, that's why across settings, I want it to be very, very important for everybody to think about where they are and where they're currently working and how this could be implemented in that setting.
Any other questions?